it's also nice to talk a little bit about our next speaker, because not all of you know him well. I think he has been very, very important for Zurich. And many of you may not be aware of that. When I came here for a postdoc, he was already Mr. Lung Cancer, and that is 2 decades ago. Rolf Stahel has also made Switzerland visible on the landscape of oncology, because he was the president of the European Society for Medical Oncology, and he was not only the president, he did 2 major things, and I think Rainer Dummer and myself, we have benefited from that. He has opened ESMO for non-medical oncologists, so it has become a very open, multidisciplinary society. We certainly appreciate that very much, and he has taken the lead, was quicker than the US colleagues, and has entered with the European team of oncologists Asia. He has started this idea of moving European oncology to Asia with very successful conferences. And fortunately, he still has a heart for Zurich, and since a few months, as many of you know, he tries to work for the cancer center here, and I think things are moving very well. So although I'm not really Swiss, I thank you very much for what you have been doing for Swiss oncology. And now he's going to talk and tell you everything about lung cancer he knows. And this is a lot.
Thank you, Michael, for your kind words. My talk will focus on clinical outcomes and the question of biomarkers in the area of immune checkpoint inhibitors and lung cancer. At the moment, these are the agents that are currently in phase 3 studies in non-small cell lung cancer. We have 2 PD-1 inhibitors, nivolumab, pembrolizumab. We have 3 PD-L1 inhibitors, durvalumab, atezolizumab, avelumab, and we have 2 CTLA-4 inhibitors, ipilimumab and tremelimumab. The focus first is what was the development of immune checkpoint inhibitors in second-line non-small cell lung cancer? What is the clinical activity? What do we know about biomarkers? Now, I have to say that, of course, in 2004, personalized therapy was introduced in lung cancer by the demonstration of EGFR mutation and a specific sensitivity to EGFR inhibitors. So, in lung cancer, patients that are diagnosed are first looked at molecularly, whether there is an oncogenic driver mutation, and those patients are treated differently than the other patients with personalized treatment. But there's still a lot of patients who do not have a personalized treatment available. So in the 1990s, last year, there was a big discussion after a first-line treatment failed, should you give a second-line treatment? Is that any helpful? And what was shown, yes, to use docetaxel was better than best supportive care. Then another drug was introduced, Pemetrexed, and it was just found it's not better, it's not inferior to docetaxel, but it's not used in second line because we used it as first line combinations. And a lot of efforts went in to improve the outcome of patients, and particularly anti-angiogenic molecules, either a small molecule or a monoclonal antibody, have shown small, significant but very small benefit added to chemotherapy. Both are not approved for use in, or not reimbursed in Switzerland. Now here comes immune checkpoint inhibitors. These have been patients treated with nivolumab, and 54% of those patients had 3 to 5 prior treatments. And then they entered the phase 2 trial, phase 1-2 trial with nivolumab, and you see the results here. And for those physicians who treat patients in lung cancer, these results are exceptional. At 3 years, 18% of those patients are alive. And this compares very well to the previously documented slides. It then, of course, a lot of those compounds enter clinical trials, and I focus on those results of clinical trials which are randomized trials. This trial looked at the comparison of atezolizumab, a PD-L1 inhibitor, and docetaxel in second-line treatment for non-small cell lung cancer. The trial was really done to do a biomarker finding. As can be seen the bottom here is, it was then later found that tumors which have lymphocyte infiltration and a PD-L1 expression did better than tumors who didn't have that. But as a surprise, it was already shown a significant survival benefit for the use of atezolizumab versus chemotherapy. Now, the big trials which had to led to registration, then nivolumab in Switzerland is registered in second line for all patients with non-small cell lung cancer, or those two trials. This is a trial on patients with squamous cell lung cancer and a trial on patients second line non-squamous cell lung cancer. You see a clear superiority of the immune checkpoint inhibitor as compared to the previous standard. We have seen from Reinhard tumor, in melanoma, there's a clear tail up to 10 years. And of course, there is hope, but we don't know that there will be a tail evolve and there will be a proportion of patients potentially cured of the disease. This doesn't look so well here with the non-squamous cell lung cancer, but if we look at the progression-free survival, we see a similar situation. There is a proportion of patients here, it's only 12%, but still a proportion of patients who have survived progression without progression for up to 3 years. So we will find out, but the hope is there that in second line a proportion of patients will greatly benefit from this treatment. Now, a similar study has been done with Pembrolizumab, also a PD-1 inhibitor. Now, there's a big difference between the previous study and this study. All studies with nivolumab have taken all comers. There was no request for the PD-L1 expression. All studies here with Pembrolizumab, the patient's tumor had to have at least 1% of tumor cells expressing PD-L1. But again, in summary, immune checkpoint inhibitor clearly superior to chemotherapy. Now let's talk about the side effects. We just maybe focus on this study. Nivolumab in patients with non-squamous cell lung cancer. Serious grade 3 to 5 toxicity, docetaxel 54%, 10% with immune checkpoint inhibitors. It's a great difference. If we want to look a little more in detail, except for alopecia, which I don't want to deal with, one of the major toxicities of chemotherapy and also of immune checkpoint inhibitor is some fatigue. But here, the rate is only half of the fatigue associated with chemotherapy. Then the question, of course, is what about the immune-related event? And this can be seen here. Of course, there is no hypothyroidism or hyperthyroidism with docetaxel associated, but you see there a thyroid dysfunction is relatively common in patients treated with immune checkpoint inhibitor and need to be checked for. Another side effect is pneumonitis, and I will go to a clinical case with you to show how scary this can be. Another way to measure outcome of patients is like to have patients report on their well-being with a validated score. These were patients with squamous cell carcinoma of the lung treated in this nivolumab study, either with docetaxel or with nivolumab. And those patients who continued on treatment with nivolumab, well, those who had a response, you see, they estimate their way of well-being similar to a healthy patient population. Now a patient. This patient, born in 52, came to us. He had a pleomorphic sarcoma, lung cancer to the right upper lobe, a clinical stage T3, N1 to 2, and the bone metastasis. He was treated with, of course, discussed at the tumor board, but then treated with 3 cycles of cisplatin and gemcitabine. He had been restaged and essentially had progression in bone, and the primary has not changed. This, you see the histology of the patient, and this was performed later on, the PD-L1 expression of the tumor of this patient. Now these are the PET scans before and after chemotherapy, and it's clearly visible. You see this huge primary tumor, not much has changed. The patient was discussed at the tumor board as a huge cavernous tumor, and we decided that he should undergo palliative surgery, right upper lobe resection. This was done, the patient recovered nicely, and he then presented back in the clinic and had restaged, and he had a clear, the lung was fine, no symptoms from there, but he had progression on bone and lymph nodes, and that hurt. We discussed it, the situation, you see here, the progression on bone and here, and also on lymph nodes. And we discussed and said we would like to treat the patient with radiotherapy and immunotherapy. He received the radiotherapy. At that time, the radiotherapists were still a little bit afraid to combine it. We would not be nowadays. And then he was treated. And after 2 doses of nivolumab, he presented in the clinic, quite ill. O2 saturation low. This was the CT scan. And he had a presumptive toxicity with nivolumab. He was treated with methylprednisolone, then prednisone, and there was also antibiotic treatment. It was very critical, but eventually after 5 weeks the patient could be discharged home. And then he came back to the clinic, and the question is, can you retreat with the patients now, and what can you give back, immunotherapy or chemotherapy in such a situation? Well, we did a PET-CT scan, and the tumor was gone. And the tumor was gone the first in February of this year, and in June of this year, again, there was no active tumor demonstrable anymore, and we followed the patient. He's now in quite good health. His question is, should he get the pension in rates, or should he withdraw all the money? And this is what we currently discuss. So, advanced disease, immune checkpoint inhibitors provide a survival benefit as compared to chemotherapy. The safety profile is clearly superior. The patient-reported outcomes suggest stable or improved health status while on treatment. The optimal duration of treatment we don't know. And should we do a biomarker selection? Should we do a biomarker selection? At the present time, these 4 companies develop with different platforms and different antibodies, companion diagnostic or an associated diagnostic. What we have to know, if you read a manuscript, that when the manuscript has durvalumab in it, and it says patients were PD-1 negative, it means they had less than 25% PD-L1 expression on the tumor cells. If you read a manuscript with Roche, which says the patient has inflammatory immune disease, it's very different. The Roche kit looks at the infiltrating lymphocytes and the expression of PD-L1 in tumor cells. So essentially, all those 4 tracks have defined different ways to classify a tumor, which I think, as you know, make it difficult for the pathologist on how to deal with that. However, we can use the data as we know, and we can draw conclusions. This has been the study of nivolumab in patients with non-squamous cell lung cancer. And you see on the top the survival outcome if there is 1% PD-L1 expression or more, and below the survival outcome as compared to docetaxel if the tumor has no PD-L1 expression. There is a clear differentiation. Now, of course, overall the study is positive, and the label says we can treat all patients with immune checkpoint inhibitors, but you might keep that in mind when you have to do an individual decision for your patients. This is the over 1% positivity in this study. The hazard ratio is 0.59, which is great, but when you break down, you have 1 to 10% positivity. Of course, very small numbers, a post hoc analysis, the hazard ratio becomes 1.3. So I think this is still evolving, and we as the treating physician, we have to learn to integrate knowledge that is emerging on PD-L1 expression in our treatment decisions. Now look at that. This is response rate in the KEYNOTE-10 trial comparing Pembrolizumab to docetaxel. They don't have patients in there with no PD-L1 expression, okay? But you see the response rate in green as a relation to the degree of PD-L1 expression in the tumor. It's very clear, the higher the expression, the higher the response rate. Now, a group of physicians with the ILSLC has looked together with pathologists and compared the 4 platforms on similar, same patients. And it was 3 antibodies and platforms performed very similar. 1 antibody and platform performed dissimilar, and this was the Roche Genentech platform. Now, Roche Genentech's antibody was selected to stain very well lymphocytes and not the tumor sites, and that explains the difference, because in the lymphocyte area the picture looks different. Now, this is about PD-L1 expression in second line. Now, let's look at another way, and we heard about that. Can there be other indications to identify patients who profit from the tumor? And this has been studied on this biomarker study of Roche, and they show that here in light blue, patients who have T-effector cells and an interferon signature in the tumor fare much better than patients with, as compared to docetaxel. But patients with no T-effectors and the low interferon signatures shown really no here superiority in compared to docetaxel. So there's still a lot to learn in the future for the best patient selection. And finally, we heard about neoantigens. Now, neoantigens, this is a calculated estimate of patients based on the mutation status by home gene sequencing. But the study here is, of RISVI shows that the outcome, progression-free survival, was better in those patients who had 200 or more calculated neoantigens. And these are the patients who have less, and this is the one here had 119 neoantigens. So from melanoma data, from lung data, it's very clear that the antigen load is also a useful biomarker, only it's not something we can use in daily practice. Now, a word to immune checkpoint inhibitors and patients with activating mutations. The Pembrolizumab study and the nivolumab studies both shown when you look at patients who have an EGFR mutation, a striking dissimilarity of the response. A recent publication in the clinical cancer research from the MGH shows in their hands patients who had an activating EGFR mutation or ALK rearrangement, the response rate was 4% only to the immune checkpoint inhibitors. So patients who are non-smokers, who have an oncogenic driver tumors, the second line treatment might not be best served for the patient if it's given immune checkpoint inhibitors. So summarizing here, PD-L1 expression is imperfect, but it is a biomarker. It needs further prospective clinical validation in addition to the laboratory validation which has been done. However, evolving data on the first-line use of immune checkpoint inhibitors suggest its use as biomarker has to become routine practice. Other evolving biomarkers, as I mentioned, not yet suitable for clinical use, is colocalization of tumor-infiltrating lymphocytes, immunologic signatures like the interferon signature, or the neoantigen load. And as I said, in the presence of an oncogenic driver mutation, the use of chemotherapy, in my opinion, is preferably second line before using an immune checkpoint inhibitor. Now, let's go to first line use. first-line use in advanced or in earlier stages of non-small cell lung cancer. What data do we have? We have here a study, this is not yet published, but it has been communicated, first-line use of atezolizumab as compared to second-line or third-line use. In this study, when the patients are selected for strong PD-L1 expression in the tumor or in the infiltrating lymphocytes, for those patients, it seems first-line use is similar to second and third-line use in terms of tumor response. But we've heard that, chemotherapy may be detrimental to some immune effectors, and we heard that from Maris, and so the data is not firm yet. But I want to show you a patient we had in this study. He was 70. He said, I do not want chemotherapy, I'm too old, but he agreed to take part in the atezolizumab study. He was treated with 2 cycles of atezolizumab, and then he felt fine, and he said, I will not want to continue, I'm fine now. So he's been followed, tumor is gone. It took 9 months when on the CT scan we saw one of the lesions had regrown. This lesion was radiated and the patient now is still fine. So 2 cycles of treatment. Now, on the Pembrolizumab KEYNOTE-1 study, there have been a cohort of patients who had no pretreatment, chemo-naive patients. And these are the results in this cohort of patients that have now been communicated at ASCO. You see the response rate as relationship to PD-L1 expression. And here is the very high 50% of tumor cells are positive for PD-L1, response rate almost 60%. Here you see the outcome as communicated at ASCO. For patients with a strong PD-L1 expression, you see at 18 months, 72% of patients were still alive, and the median was not reached. For patients who had 1 to 49% expression, it was the median survival is 19 months. So it's very exciting data, and of course, everybody waits now for the phase 3 trials. Similar data has been presented by nivolumab, also in the first cohort. What been shown is, you see here the response rate in relation to the degree of PD-L1 expression in the tumor. And these are 12 of the currently ongoing phase 3 trials in advanced non-small cell lung cancer. In total, about, I don't remember, almost 10,000 patients in clinical trials. We have indirect results of 2 trials of KEYNOTE-42 and Checkmate 26. Of those 2 trials we have information. The first information is this press release of Merck. They said the trial was prematurely closed because on recommendation of the data monitoring committee, because of the benefit of first-line immune checkpoint inhibitor versus platinum-based chemotherapy. It has been accepted and will be published soon. There has been another press release on the BMS study. Now, the Pembrolizumab study mandated 50% expression on the tumor. The BMS study mandated 5% of PD-L1 expression, and there was an announcement that they have a different endpoint. It was progression-free survival, which is a very difficult endpoint for immunotherapy studies. This study was negative for the major endpoint, progression-free survival. Of course, we do not know what the other endpoints will show. Now, we hope that both those studies in detail will be communicated by the end of the year. Reinhard has shown that in melanoma it appears when the tumor is PD-L1 negative, if you add ipilimumab to nivolumab, there is a benefit of the combination. Now everybody then would assume that in the lung cancer it should be the same. Now these are cohorts of patients treated in KEYNOTE Checkmate 12. And this cohort of patients were treated with nivolumab alone in gray or with ipilimumab and nivolumab in different schedules, but I don't want to go into details. And these are the very few patients, of course, but less than 1% expression. That is not so much a difference. But as soon as there is some PD-L1 positivity, you see the combination of ipilimumab and nivolumab gives tremendous response rates. Of course, the treatment is also more toxic, but it's very encouraging and might be one of those steps that Reinhard mentions. The combination of different immune checkpoint inhibitors will provide further benefit, and this is a glimpse into that. Now, of course, the question is, what about patients who have chemoradiotherapy curative approach? And we have an ETOP study on nivolumab for patients on curative chemoradiotherapy. 5 patients from here, from our hospital, have already been included in that study. Of course, you can also think in surgical studies, stage 3 disease, where Switzerland has a big tradition in those studies. And there's also a study of the SIKK who looks at intercalating after chemotherapy a PD-L1 inhibitor for 2 cycles prior to surgery and then as maintenance in a phase 2 design. There is also a study, this is also here done by ETOP, and we're participating in our hospital. It's a study of the adjuvant use of an immune checkpoint inhibitor after completely resected patients who had or did not have immunotherapy, and this study has started a few months ago. So there are over 12 large randomized studies of immune checkpoint inhibitors ongoing in first line. We heard the results by press release of 2. Of course, this is not the scientific data yet. Combinations are undergoing examination, particularly also combinations with chemotherapy are currently ongoing. And we have stage 3 studies ongoing. Now, very short glimpse at other thoracic malignancies. There is published data in Lancet Oncology that in small cell lung cancer, the combination again of ipilimumab and nivolumab seems to be particularly effective. And this is the reason why our ETOP study, which are patients who had limit disease, small cell lung cancer, who were treated with chemoradiotherapy, the ETOP study now has been amended to use ipilimumab and nivolumab in a randomized fashion as compared to observation. And it's a great hope that this will be the study that will show how we can increase the cure rate of limited disease small cell lung cancer. Another tumor is mesothelioma. You know that we are a center of reference for mesothelioma, and there has been data presented 2 years ago, in 2015, at the AACR meeting of Pembrolizumab in patients with PD-L1 positive mesothelioma, and shows a response rate of 28%. It took us a lot of initiative, but there will be a study of ETOP in Switzerland and the UK on patients who have mesothelioma and have relapsed disease, 2nd or 3rd line, where the patients will receive Pembrolizumab or randomized chemotherapy by institutional choice. If there is progression, crossover is allowed, and this study is also supported in Switzerland by the SUVA. So a lot of is ongoing, and I'm looking forward to discussion and answer your questions. Thank you.